Thank you so much for having me, and it's a real pleasure to actually present this. I hope everybody can see my screen.
Yeah.
Okay, good. So the reason I label this talk as actionable outcomes prediction is a lot of the work that I do is, as Aminat mentioned, that I do a lot of work on, biomarkers and the use of biomarkers for clinical outcomes. This is kind of an important topic. What it does is it takes the clinical questions and from the physicians directly, and what we do is we develop strategies to actually predict those outcomes. Now those outcomes can be those biomarkers can be either lab-based biomarkers, or they could be computational or mathematical models that can actually predict a certain outcome. So with that, these are the contents of my presentation. I'll be discussing the research areas I work in, the current publication on COVID, and the ongoing validation effort for that, and future works on COVID-19. So I have nothing to disclose. And these are the areas of research that I work in, which includes biomarkers in the tumor microenvironment, in chronic diseases like diabetes and cardiovascular disease, preventive medicine, and machine learning more recently. So these are some of the papers that we've published on machine learning biomarkers and non-machine learning biomarkers. So there's a lot of lab work in there. There's a lot of computational work in there. So, and these are some more papers exploring biology of tumor. And these are the machine learning papers, the relevant ones at least. The publication that I'll be discussing is predicting mortality in COVID positive patients in the inpatient setting using a novel deep neural network. So the way we came to this is the first question that we were asking is, and it was from a point of view of being a physician, is that can we have a data set that is reflective on that is reflective, that if a variable is associated with worse or better outcomes, can we leverage that to develop machine learning strategies around it? So what we did was we developed Flame first, and then we developed NeoV. And the way we did that is, what I usually do is I explain how biomarkers work, and this is a very direct way of explaining that. You have clinical data, you do a biomarker analysis on them, and you give a prediction. Did the patient survive, or did the patient die, or did the patient actually got disease, or did he not get disease? Did they respond to treatment, or they didn't respond to treatment? And once you have that information, for people who actually died, even on can we change something, can we change the management? So it actually incorporates directly into clinical practice, that we can actually characterize patients that will potentially die at the end of admission, and if they have certain risk factors, and we'll give a prediction on that. And then can you use that prediction to actually change the outcomes? And the most and the thing we want most is, as time passes, our biomarkers starts to fail, because what that will do is it will show that now the mortality has shifted because there's a change in management for the patient, and more patients are surviving, and it's not picking up mortality anymore. So that's the ideal situation that we would want to be in. How biological quote unquote machine learning works is, how can we find associations between risk factor and a relevant variable, right? So what we do is the first thing that we do is we do rigorous statistics on everything, all the variables that are included in a data set with the outcome. And can you actually have variables that are more predictive of mortality, or benefit or harm, and then leave out all the other variables, that were not associated with the outcome. And what this does, and the first two foundation papers were on this, and the way we did it was we did a lot of most of my work on in this field is on mortality prediction. So what we did was we took out hazard ratios using Cox-regression multivariate analysis, that is this patient going to die at the end of admission if this risk factor is present, right? So, and then we actually ranked them and we removed all the irrelevant risk factors and we supplied it to the machine learning. It turns out that the models actually, what happens is the models actually do much better when you give them a much cleaner data, which is relevant to the outcome. It. And then the third case study was actually the COVID paper, in which what we did was, now what we did is how can we actually improve further this two-tiered framework. So we developed something called NewV, and the way we did that was, instead of supplying the statistically significant risk factors for to the machine learning algorithm, what we did was we introduced another phase in between the two phases. Now it became from a two-phase into a three-phase framework. In that, what we did was we created neo variables. Now, the way we created new variables, we actually got a response from one of the journals, and they said, oh, why is this not just combination of two variables? And then we had to explain how and why we picked each variable and combined them. The only reason we combined two variables or more is because they are biologically part of the same system. For example, you have respiratory system and you have the cardiovascular system, you have the coagulation system. And if the two variables are part of one of those systems, then we combine them. Other than that, we didn't do a random combination of things. And so it actually is reflective of that we're trying to follow biology as much as we can. So what this does is it gives you more data for a smaller data set, and then we supply that to the machine learning model. So we did present this before the paper was published at AACR, which is held in the United States, and their virtual meeting on COVID-19 and cancer. And the aim of the study was to look at, can NewV outperform other models? And so we hypothesized that our model would actually do much better. Now, the data we got was from Aga Khan University Hospital in Pakistan, and the way we got the data was that, it was when the pandemic started, I actually sent out a request, put out a request on LinkedIn that, we are looking for a data set and we want to work with potential collaborators. And one of my old colleagues, Dr. Naseem, who's the first author on this paper, she approached me and she was very nice, and she was like, oh, we have this data between April and October. Would you like to work on this? And we worked together, and she did a brilliant job in collecting a very granular data set, and it had everything that we had asked for. We developed the protocol, we gave it to her, and she did a brilliant job of putting the data set together. So in total, we had 128 patients. We excluded all patients that were proven negative for COVID-19 or had incomplete health records, or were pediatric patients less than 18 years of age. So this is the overall study design. Once all of the data was collected, we did two experiments. The first was the FLAME framework, and the second one was the NewV, the one that we were testing here. And these are the results for that. We observed that there were several clinical and lab-based risk factors that were significant in both the univariate and the multivariate analysis. And the most significant of them were septic shock, supportive treatment, abnormal INR, admission to the ICU. If you were admitted to the ICU, you were 3 times more likely to actually die from the admission. Even though this might be reflective of the overall condition of the patient, but just getting admitted to the ICU, you could potentially die. Treatment with invasive ventilation, that means the patient already had respiratory failure and now was being treated with invasive ventilation. laboratory lymphocytic dearrangement, and then that's the link to the paper. And these are just the demographics of this population, and we did statistical analysis on everything, and these are the comorbidities that these patients had, and apparently there was some comorbidities that were significant in the univariate, but they fell out during the multivariate analysis. So we didn't include them in the machine learning process. These are just the symptoms of each of these patients, and more symptoms, and then clinical characteristics. We also saw point of care. For example, special units. Aga Khan has a 3-tier system. Either you could be admitted to the general ward or a special care unit or the ICU. The special care unit is actually a step down, and um, it's not it's not the ICU. Neither is it being admitted to the ward. So it's in between the two. And we also looked at that if some patients were admitted to the special care unit, did they have a higher chance of dying? And the number of admissions in the ICU during that hospitalization. And it turns out the more times you get admitted to the ICU, you're already sick, and that means you're clinically unwell, that that the patient was doing well, and then they were sent to the ward or step down, and then they went back into the ICU. We also looked at radiological evidence for this. Routinely at Aga Khan University Hospital, they don't usually do a CT scan of the chest. They just do X-rays, and they rely on. Back then, they were relying on the PCR test. So most of these patients actually received a chest X-ray, and then and quite a lot of them had positive or negative findings, but they didn't held through. We looked at a lot of labs, including blood counts, including lymphocyte, neutrophils, platelets, serum albumin, ALT, APTT, and bilirubin. And there's a bunch of labs that we looked at, which I'm not going to go through, and it's just gonna take time. And a lot of them were significant for mortality. A lot of them weren't significant for mortality. And the ones that were significant for mortality were actually, we expected them to be associated with mortality. And during the time that this data was collected, there was no specific treatment for these type of patients. The vaccine wasn't there. We weren't sure how to actually treat it. So there were a lot of patients that were treated symptomatically. There was a lot of patients who were given just supportive therapy. Some of them actually received steroids, and so there's a lot of treatments that actually were given to these patients at that time. So for the phase 2, what we did was we looked at total number of comorbidities, and we looked at if a patient had 2 or more comorbidities. We looked at the total number of symptoms, total number of treatment received, and then we had the combination of variables that I previously discussed. They have to be biologically relevant. For example, creatinine and BUN, they both assess kidney function. So they're actually part of the renal system. Hemoglobin and hematocrit, they both assess the oxygen carrying capacity of the individual. Platelet and INR, they're both involved in coagulation. PT and INR, they again 2 parameters from the coagulation system, and TLC and lymphocytes. They're part of the immune system, and so is TLC and neutrophils, and the total number of lab abnormalities that were present in those patients. So our best model was the deep neural network model for this population, and it outperformed others. It had a testing accuracy of 99.53, which is an internal test, and a sensitivity of around 90%, and a specificity of 95%, and a positive predictive value of 50%, and a negative predictive value of 91%. And if you ask a clinician, what kind of a test would you love, and you give them really high sensitivities and specificities, they would always tell you that, okay, so this test is positive, but you know what is the positive prediction on this, that if a test is positive, that this patient will die, right? So that's where the post-test probabilities of positive and negative predictive values come in for a positive test. And the negative test, if it was really negative, did the patient really survive? If there's a positive test, did the patient really die? So that's why we like to concentrate on these, so that it reaches the clinicians and they say, oh, you know what, I think this has a better positive predictive value than our traditional scales, so we might just be able to use it. And we had a AU-ROC of 88.5. And this is just a comparative analysis of the different methods that we used. I'm not going to go through all of them because they're quite a lot, and you can read the paper on this and go through and look at each of these algorithms, how they perform. So our deep learning model actually outperformed our previous deep flame model, and NeoV, random forest, KNNs, and others. The next step for us was an external validation. Okay, so we have this great tool. Can we use it, in different settings in different parts of the world? And for that, you would want to do an external validation, to be really sure when you say, oh, this algorithm actually works. And so what we did was, we recruited physicians here in Detroit from Detroit Medical Center. And what we did was, we developed a protocol, we put in an IRB, and we started collecting patients. And they collected patients. So no, so there are a couple of caveats to this. By that time, vaccine had came out. A lot of people were getting vaccinated, and so, and there were some people who were admitted, even though they had vaccination, but they were admitted to the hospital post vaccination. And then there was a lot of there's actually a lot of difference between the two populations, which I will go through in my next slides. What we also did was we went out and developed another, we recruited more physicians from Beaumont healthcare system in the US, and they're in the process of collecting the data right now. For the DMC data, we did the validation on that, and which I'm going to go through the results with you just in a bit. So how did the external validation went through when we put in the DMC data? So please note that some of these values were missing from the current data, the validation set, because what was happening was, because even though DMC is a big medical center, and it serves a large population of Detroit, and Detroit is a very big city. And when you have a lot of infections and when you have a lot of admissions, what that does is, it puts pressure on the physicians to actually treat the patient, and have a revolving door sort of an approach, that whoever comes in, we treat them enough that they can go home and ride out their symptoms. What that does is it decreases the amount of testing that's being done, and it also decreases, it actually fatigues the physician, and then it also puts a strain on the resources of the center. And then you need to have this continuously revolving door approach, that you need to get as many patients back home as possible. So the current great data that was collected at DMC wasn't that granular, and we had some missing variables from that. And it was a predominantly African American population, even though our data set was developed on South Asian Pakistani population. We were applying it to a completely different population, and it was really exciting for us to see that, can this actually predict mortality in predominantly African American population, which is ethnically different, which is which is a completely different populations in terms of overall healthcare, in terms of overall nutrition, and being of having completely different genetic makeup. So for that, we had an accuracy of 64.5, which was not as great as what we had, but that was what we got, and a sensitivity of 84.3, a specificity of 34.6, a positive predictive value of 66%, and a negative predictive value of 59.4%. So we had around 70 that were true positive, 36 that were true negatives, and 19 that were false positive, and 13 that were false negative. We collected around 132 patients, and then we didn't for the validation set, you don't actually need a very large number of data, because what you've already done is you've developed an algorithm, now you're just testing it. So we needed a very small number. And this is the AUROC. I know it's not great, but what was really great to see is, it did perform relatively well. And that is why we are actually very excited to look at data from Beaumont, because Beaumont is going to provide us with, again, 150 patients, and then we'll rerun our algorithm. And if that doesn't work, which could be possible, which we are anticipating that might happen, that is where our next steps come in. So our next step would be to develop population specific algorithm for mortality in South Asia, United States, in different ethnic populations, and in populations that are diverse in nutrition, diverse in overall health, and they're diverse in the geographical aspect of it. So we're still waiting on Beaumont to give us that data so we can do a validation on that. And this is as far as the story goes. And thank you so much for listening. I know I've done a little bit early. We would get more time to talk, I guess.
Yeah, thank you. Is there any question from the audience?
Hi, thanks for the talk. So just to understand, so this neural net model and you compare it to other alternatives, to k-nearest neighbors and random forest. So within the rich class of neural nets, can you say a bit more about the structure of the model, and what are the input features, and what were considerations in designing the neural net architecture?
Right. So our neural network was, what we did was, most of the machine learning was done on Python, and we used the MLP classifiers. We didn't have a very large network. We had a network that had 2 layers. One layer having I think 7 nodes. I don't know on the top of my head, and the other one had lesser nodes. So we trained it on that, and the reason why we use this is because we've actually used it before in post-operative ILS and patients being admitted to the trauma ICU. So so that's why we were using that sort of a structure. And the input that we were putting into that was binary input. Was a risk factor present or not? And then we looked at we also did a lot of statistics on them. What that did was remove all the stuff that wasn't relevant to the actual outcome, because we wanted to predict the have variables that were actually associated with the outcomes. And that's why I mentioned the foundational papers, is because the way we look at disease processes and their prediction should be in the realm of can you actually is a risk factor associated with that outcome. So I hope that answers your question.
Yeah, okay, thanks a lot.
Thank you.
Yep. Any more questions? Um, so like, can I ask, like, so like this tool, like, is it like like, is it going to be used by like medical experts later on, like
Right.
like the diagnosis?
Right. That's a very good question. And that's the reason why what we did was, when we were publishing this, if you go to the last reference of the paper, we've actually put it online. So any physician around the world, but we've put that caveat that this is a research tool and this needs to be further validated. And until that external validation is done, we won't, people can use it, right now, but with the caveat that this is an unvalidated tool, right? But and that is what we want. Because in the United States, we've been using machine learning in radiology a lot, because, for example, if you have a lung lesion, is it malignant versus non-malignant, so it's a tool that's approved by the FDA. So we want something like that for ICU physicians, for physicians in the ER, for physicians in the in the ICU setting. To reach that, we have to have enough validation of this tool, so that we can say reliably, and that this tool actually works. So that's what the ultimate vision is, and that's why we wanted to do a secondary study on external validation, which is completely independent of the data set that we already had. And if that doesn't work, that means we need to go back and look at it, and look at the data again. Is there a different way of actually looking at this data, to actually improve the overall accuracy of the algorithm?
Any more questions from the audience?
Maybe I will ask one.
Yeah.
Well, can you just talk a little bit about how was your, say, approach in balancing the extensibility and usability of your tool? Because it's like, it's always a challenge to make the tool easy to extend and like to add some more scripts as you go, and also makes it easy to use, like user-friendly approaches like GUI. So
Right. So what we did was we went, the question was, once the paper was complete, okay, so this is a great paper, this is a great tool, what do we do with it? What do we want to do with this? So then, a couple of us suggested that why don't we actually have a web tool that is accessible to everyone. And the way the web tool is designed is you can play around with it, change the different parameters, and you can actually have look at mortality changing with each of those parameters. So we built that on Streamlit, and it's part of it is part, and then I put the link for that application. And the way we extend this is, right now we've closed the model off, right? We want to validate it. And if it doesn't validate, then we'll go back and, reevaluate our approach, that do we need to change something? Do we need to add something? Or do we need to actually approach this problem from a different point of view? If you think about it, what we're actually doing is we're looking at mortality right now. What we can do is we can actually change the outcome and use a similar approach, which uses statistically significant variables for length of stay, for ICU admission, for long COVID. Now that we know that there's something called long COVID, in which you have complications of COVID that go beyond the initial infection. So what we're trying to do is set the precedent for that, is that, whatever we do next, we can actually train this tool again, and then and look at other outcomes.
thank you.
Yep. Any more questions? I think, all right, that's it from the audience. And it's a great talk. And then thank you very much for joining us in our seminar series.
Thank you so much for having me.
All right.
So I would like to take a
thank you.
moment to thank you for inviting me. And I do a lot of collaborative work on outcomes research. And if you feel like that, there's something that we can work together on as a collaboration between, Wayne State and University of Queensland, we can actually do that. You have my email, and you're more than welcome to approach me on that. Thank you so much for having me.
Yeah, thank you. That's very kind. Thank you.
Thank you.